Hello, everyone, and thank you very much for joining us today. My name's Deborah Garlick from Henpicked, and I'll be joined by my wonderful colleague Sally Leech from Henpicked. And what we're going to be covering today is living with adenomyosis can be painful, exhausting and confusing, especially when it takes so long to get answers. Heavy bleeding, pelvic pain, fatigue, and brain fog can affect everyday life and well-being, and of course, at work. Yet this condition is still widely misunderstood. So we're going to explore Sally, you're going to have to help me with the
Yeah,
pronunciation.
this is really common, adenomyosis, because it's not a word we say very often.
And especially when you've got new braces. So no need to adjust your sound. Yes, I've got new braces in. But actually, adenomyosis, many people have never heard of it. Yet so many people have told us just how difficult it is experiencing this condition, getting the help and support. So we wanted to have this session today to really dig deep in understanding the condition itself, the menstrual health condition, understanding how that might present and what you can do about it. So, Sally, I'm going to ask you a couple of questions, first of all, to really get to the basic information. But I'm going to ask everyone, do share your experience in chat. We want to answer as many questions as we possibly can today. So I will start with Sally. How many people many people may not have heard of the term adenomyosis. So what actually is it, and do we know what causes it?
Yeah, thank you. And absolutely, whenever we're doing sessions on menstrual health, it's amazing how many people thank us when we talk about adenomyosis because it's not something that's spoken about. Many people might not have heard of the word before. It is very much that lesser known menstrual health condition. But actually, according to the NHS, it affects 1 in 10 women of reproductive age. So we think in the UK that's over 1.5 million women, around 176 million women globally. Some studies have shown it's as many as 2 in 10. So it is a really common condition that affects a lot of people. It's commonly diagnosed in women over the age of 30, but it can affect anyone who has periods. But in terms of what it actually is, so it's a condition where the tissue similar to the lining of the uterus, so the womb, grows into the wall of the uterus. So each month those cells react in the same way as those do in the womb. They build up and break down and then bleed. But unlike the cells in the womb that leave the body as a period, this blood has no way to escape. So it can cause inflammation, pain, the formation of scar tissue. So it's very much so from a clinical or technical point of view, it's when that endometrial tissue invades something called the myometrium. So that's the muscular layer of the womb. And that can lead to a really enlarged uterus and severe menstrual symptoms that you've mentioned. So there can sometimes be a bit of confusion between adenomyosis and endometriosis. So endometriosis is again where that endometrial tissue grows, but it grows outside of the uterus, whereas adenomyosis is just where it is involved in growing into the uterine wall. So it can be confusing and some symptoms can be similar, but also it can be very common for people to have both adenomyosis and endometriosis. But in terms of adenomyosis itself, it's very much when that thickening of the wall happens. And that's the way, and we'll come on to talk around diagnosis of that's what is the kind of clear clinical I guess confirmation that it's adenomyosis. And there are different types. It can be some people can have adenomyosis with no symptoms, some can have quite extreme symptoms. And there, some in terms of some of the terminology people may hear, there are three different types. So focal adenomyosis is when it's in one particular site in the uterus. Adenomyoma is a type of focal adenomyosis, and that's a bit more extensive. So it's normally a larger inflammation or formation of scar tissue. And then diffuse adenomyosis where it's spread throughout the uterus. But the type doesn't always isn't always relevant to the type of symptoms. And from a cause point of view, it's unknown. There's some research around the impact of things like hormone imbalances, genetic factors, previous uterine surgeries may contribute. But as with much of women's health and menstrual health, a lot more research is needed.
Absolutely. And, Sally, as you're saying that, I can see people putting notes in chat, which I really feel for you. I suffered badly with this. It's very painful. I've only recently been diagnosed. I was diagnosed when I was examined for something else. And, so many people do not know this. You're right. Many of us have heard of endometriosis, but adenomyosis, absolutely nothing.
Yeah.
So, what symptoms could somebody experience?
Yeah, so we've talked about some of them. Those severe cramps, chronic pelvic pain is very much the way people often describe it, and that kind of bloating and pressure in the pelvic area, heavy and prolonged bleeding, pain during intercourse, and then often fatigue due to or anemia due to the heavy bleeding. So there's a couple of key things here to be mindful of. If someone's experiencing heavy bleeding, having iron levels checked is really important because anemia can be really hard to manage and can really affect how we function on a day-to-day basis. But it's also a lot of these symptoms we often normalize, and this is some of the challenges around both in terms of ourselves advocating and getting help and support, but also when we're talking to healthcare practitioners, and we can come on to talk around that. But if anyone who's on this call, and I'm sure say some of those lived experiences, if you're experiencing severe pain, if you're experiencing really heavy bleeding, then we should be saying that that's a sign that something may be going on that is causing that. And it's so important that we don't normalize and think, I've just got to put up with it. But actually, these are signs something's going on, and there are things that we can do to manage this, and we can talk about that. But I think it's very much the impact this has, and we can hear from those stories. So living with adenomyosis can be a real challenge. And I just want to share a few bits from people we've had that have really shared their own lived experience. I think there's something about living with pain. Anyone that lives with pain for all manner of reasons know it can feel really debilitating. It can make it difficult to carry out everyday activities. And I think anyone who's on this session who doesn't live with that pain, understanding and recognizing and acknowledging that that can be the lived experience for someone is really important because if we have, maybe a relatively regular cycle with some kind of mild period pain, actually recognizing for somebody getting out of bed can sometimes feel really hard when that pain is really severe. I think there's quite a sense of emotional strain. And a lot of this comes down to the unpredictability of symptoms, and we hear that a lot from people. There's no kind of predicting when symptoms are maybe going to flare up, and that can lead to that kind of real emotional distress. People report to us of feeling really frustrated, often feelings of anxiety or depression associated with a chronic condition. It can have an impact on relationships. We've talked about pain during intercourse, so that can affect intimate relationships. But equally, the need for frequent rest, medical appointments, not feeling comfortable or able to be involved in social activities, the impact on work. It can affect both or put a strain really on personal and professional relationships. And as I mentioned, just one final thing just around that fatigue is say, I can't emphasize enough that heavy menstrual bleeding, it is a sign that there is something going on that we shouldn't have to put up with. And there are many, many things that can be done to help manage that because that are, say, leading to anemia. And when we say heavy bleeding, sometimes people say, well, what does that mean? This is very much if you're needing to change your pad or tampon every 1 to 2 hours or menstrual cup more than is recommended. If you're having to use two types of period products together, such as a pad and a tampon. If periods are lasting for more than 7 days. If you're having large blood clots, so they're kind of bigger than a 10p coin. If you bleed through into your clothes or your bedding. If it's making you avoid daily activities like exercise or you're having to take time off work because of periods. So those are the signs that actually that's having an impact on your quality of life. And actually that's the time that we need to ensure we're gaining that help and support in how we might manage that symptom.
And Sally, as you were just describing that, I can see comments coming up in chat saying it's absolutely excruciating. Now, you do so much, and you're my superhero for this one, the amount of training that you do in workplaces. And very often, what we hear from women is this is something we just put up with. It's one of those things that what is normal, we never taught what's normal. And if you do say something about this is really, really painful, you get people saying, well, that's just part and parcel of being a woman. So it's worth you reiterating the what is normal.
Yeah, absolutely. And we always talk about it, about the impact it's having. So if what you're experiencing is having an impact on your quality of life, then it's really important that we think about how we might get the help and support we need. And that can be, and we can talk around, talking with healthcare practitioners. There are some lifestyle things that you might want to try that could help and support. But it is about, because of say we don't have a frame of reference because we don't talk around menstruation, actually when we realize what periods should feel like in terms of it shouldn't be that excruciating pain, it shouldn't be heavy bleeding for more than 7 days at a time. It's amazing the difference it makes once we know actually this is a sign that I need to understand what's going on, and actually starting that route of diagnosis, in which we can come on to talk about. We know there are challenges around that. But yeah, I think it's so important that we have a frame of reference for normal. And in a lot of our sessions, we have people say, I'm just reading a feedback recently. I've someone saying that they were nearly 50, they've got over 35 years experience of periods, and they never learned as much about their body as they did in that hour because no one had ever told them. And we've had experiences from people saying they're going through, been through childbirth, and someone said this is going to be really painful, and someone saying actually compared to the pain I live with daily, this is okay because they just normalised that that was what they had to put up with.
And what we need to normalize now is that understanding of there are these conditions, this is what you can experience, and this is what you can do. So, how would somebody get diagnosed?
So it can be challenging. The length of time for diagnosis is really long, but some of that is where we need to really be able to advocate for ourselves within our healthcare settings. There is a lot of work being done on women's health support within our healthcare service, but there is a lot of there's still a lot that needs to be done. And some of the experiences we hear can feel that people aren't really being understood or being listened to or being believed, and that kind of dismissal. You're just one of the unlucky ones. We've heard that before. Or as you say, this is just part of periods. You know your own body and you know if something is having an impact on your quality of life. In terms of diagnosing, it's normally a combination of somebody may do a pelvic exam. So your healthcare provider may notice the uterus has got larger, it may be softer or it might be painful to touch. Normally, it would be something like an ultrasound, so a transvaginal ultrasound where the waves produce images of the pelvic organs, and again showing that image of the thickening of the uterine wall. MRI scans sometimes used again to show that uterine enlargement. And they're really those kind of imaging techniques that help doctors visualize that thickening of the wall and confirm that diagnosis. But one of the challenges, again, around adenomyosis and endometriosis is, according to Endometriosis UK research, it's estimated around 20 to 50% of women with endometriosis also have adenomyosis. So it can start to become really complex. And actually diagnosing endometriosis, it needs to have a surgical procedure called a laparoscopy. So somebody who has adenomyosis through an MRI scan, they may still need further investigation to see whether there is also endometriosis present. And the reason why it's so important is that kind of co-occurrence can help or inform decisions around treatment options. The way someone may choose to manage adenomyosis may be different to if someone has adenomyosis and endometriosis, because some of the, especially some of the hormonal treatments may flare up endometriosis but manage adenomyosis. So it's complicated. But I think the big thing is all about that self-advocacy and that recognition that as much as we would love there to be a great experience for everyone then when they go and see their healthcare practitioner, that isn't always the case. And we had a really tough story shared by somebody. So she was told about her diagnosis of adenomyosis over the phone after years of being dismissed. The conversation was given about 5 minutes and she was told she might need a hysterectomy. She was in her late 20s and still wanted to have children. So that we know is the
Wow.
current lived experience for some people. A lot of the treatment options have big decisions to sit around them in terms of long-term health, life choices, where someone is in terms of their age. So I think it's really important we recognize that it can be challenging to get a diagnosis and then it can be challenging to work out what the right approach might be.
Interesting, isn't it? Because if we wind back the clock, and actually so many women still experience this with menopause, that you do have to be persistent and say, actually, I know my own body and what I'm experiencing, and reading the comments in chat is excruciating. We want everybody to be able to thrive in life and at work. So sometimes it is that acceptance that it's going to be a longer journey, but
Yeah.
you're going to have to keep pushing it and asking for. I'm seeing a lot of comments in chat around. I was referred to a gynae
Yeah.
when because actually they were persistent, and that's what good looks like.
Yeah, absolutely. And when we talk around advocating yourself, yeah, that referral is often really important. If you're not feeling like you're being supported, or that maybe a first line treatment the GP recommends, and we'll come on to talk around treatment. So something like the contraceptive pill or the coil is not managing your symptoms. A gynecologist may be the best person to talk to, and actually saying, talking about adenomyosis and saying you want to see a specialist to understand whether that's what's going on and to make decisions around what might be the right treatment option for you. Because our GPs are general practitioners, and actually, adenomyosis is a complex condition, especially if it's affecting someone really severely. And actually, that specialist person, but also if you're having that referral, asking to be referred to a gynecologist with specialist knowledge of adenomyosis, if that's possible, is really important.
Okay, that's wonderful. Thank you, Sally. It's worth us looking at some of the treatment options because I, like Debbie, I don't know if I had adenomyosis. I had very painful periods during my menopause transition, and the GP's response was to give me very heavy pain control, which, and I love Debbie's quote here, but sent me away with the fairies. That's exactly my experience. It wiped me out, made me feel like a zombie, and I was expected to live like that for about 10 days every month.
Yeah.
It's not doable.
No.
So, what are the range of treatment options available?
So there are a range. I think, again, as with much of women's health and menstrual health conditions in particular, a lot more research is needed, a lot more consideration around what treatments could be developed in the future. I think it's really important. So some GPs may focus first of all on hormone therapies, so options like the coil or the pill. Some may look at things like GnRH analogs. I'm going to come on to talk around those because that's it's a really important. Some people may never have heard of those, but some quite considerable big considerations around that. One of the things that some people sometimes share with us is feeling dismissed if they're offered the pill or the coil as a solution. I think one of the GPs that we work with said that they will often suggest the pill or the coil to help manage those symptoms while maybe looking for a diagnosis or understanding what's going on. So it's not going to cure, but it might help manage that quality of life. So that is often where that comes as that first line treatment. But it should still then be, how do we actually understand what's going on? So it's not a full stop, right, take this and then the job's done. But that recognition that actually some of those things, we've had people that have shared, having the coil has made such a difference because their massive symptom that was causing them major problems was the heavy bleeding, and the coil managed that for them. Now that will be different for everybody. So it's recognizing there are some treatments like that that could help. Pain relief is definitely one of them. Even over the counter pain relief sometimes. Some people have talked about things like TENS machines, anything that kind of manages that pain. One of the big things, if you go and see your GP around the fact this is causing you challenges, making sure you're letting them know what medication you're having to take to get through. So if you're having to take strong painkillers, if you're having to take painkillers for X number of days a month to be able to survive, let them know, because that help is not them masking the symptoms you're experiencing. They can really see that this is something that you need to that is actually you're having to take action on to be able to manage. There are surgical options, so hysterectomy, oophorectomy, endometrial ablation. There are lots of things from a surgical point of view that have quite, again, big decisions behind them. a hysterectomy is not a straightforward operation. It's a big decision for somebody, can push someone into surgical menopause, considerations around long-term health, where someone is from an age point of view, what their plans are in terms of family. So there's a really big decision around that. And it's why I just wanted to mention a little bit about GnRH analogues, which some people may never have heard of. So these are a medication that puts someone into a temporary menopausal state. So it's that medically induced menopause, so reducing the production of estrogen and progesterone. So it stops menstrual periods and reduces, in particular, symptoms relating to pelvic pain. Um, so if we think then it's taking someone into a medically induced menopause, it means then people could start experiencing some menopause symptoms, so hot flushes, mood swings, depression, brain fog. It is considered to be an effective option for managing symptoms, especially if other treatments not providing that sufficient support. But again, it's about discussing that as an individual. GnRH analogues in general are typically used for up to 6 months due to the risk of bone thinning, so the risk of osteoporosis associated with long-term use. However, there can be something called add-back therapy, where a low-dose HRT hormone replacement therapy is prescribed alongside the GnRH analogues, which can extend how long someone might be able to take it, normally up to about 2 years. Then there's normally considered to be a 6-month break, a check on something like a bone density scan, a DEXA scan, just to check around the long term or kind of monitoring that bone health. But when we think about the idea is the add back therapy helps to manage any menopause symptoms, but we think about how this might feel. So imagining someone in their late 20s, early 30s, living with incredible pain and heavy bleeding, and then needing to make a decision to try something that will induce menopause. It's a lot to deal with. So I think it's a real recognition. Treatment options are really complex.
I think there's a lot to recognise here, Sally. I mean, I didn't know about adenomyosis at all until you highlighted it. I know that your sessions in organisations go down an absolute storm because many of us don't understand these menstrual health conditions and put up with things when actually there is a solution. But you've got to look at the chat there and see how many people are really struggling with this. And that does have an impact on work, and it does have an impact on life. With all of that. So I'm going to ask because there's hundreds of people on this webinar and there's hundreds of people who will watch this again. What can we do about this in society? How can we raise awareness of this? We want everybody to know about this, and we ask everybody to join in being able to talk about this. So I'm going to say a huge thank you to everybody. This is such a lovely community of people sharing their experience and actually being supportive to each other.
Absolutely. And we've got some top tips that we've had shared from people who have been really brave in sharing their stories. So people have talked about how they manage symptoms at home. So even simple things like heat pads, hot water bottles. We talked about TENS machine, over-the-counter pain medication. It just, again, it has that kind of almost like toolkit of things that they find has really helped them on those particularly bad days. Emotional support is really important. So seeing the chat and people sharing their stories, joining support groups, online communities, connecting with other people who are experiencing the same thing, knowing you're not on your own. That feeling of isolation can be really common, especially if people are feeling dismissed or it's not recognized, it's not talked about, and people feel they're having to that focus on that kind of suffering silence that we want to try and remove. What I would say, if anyone's feeling this is having a really big impact on their mental health, because this is a chronic condition, and it can have, people have shared feelings of anxiety and depression. Talking to a mental health professional, getting that support from an emotional point of view is really important. There are some dietary things that can sometimes help. Now, this will be different for everyone the same way when we talk around menopause, when we talk about endometriosis, PCOS, it's different for everybody. But things like trying to include more anti-inflammatory foods. It's very much an inflammatory. Think about that bloating feeling. So anti-inflammatory foods, veg, nuts, seeds, fish rich in omega-3, limit inflammatory foods. So things like processed food, sugar, dairy. high fiber diet, hydration, those things are really important. Regular physical activity, stress management. But I think one of the biggest things we can do in terms of supporting this is think about how can we encourage advocacy from a healthcare point of view. I think it's recognizing that need for further education. We've started to see that around menopause. We've started to see, in particular, around endometriosis. There is definitely more talk around this. Adenomyosis needs that same kind of spotlight and attention. And there are some top tips we'd say around talking to your GP, preparation, tracking symptoms, so important. But as I say, not just physical symptoms, but the impact it's having and what you're having to do to try and cope with day-to-day life to show this is something that needs to be taken seriously. It's not just I'm having a bit of heavy bleeding and I've got a bit of period pain. It's so much more than that. And that's what it sometimes gets dismissed to. So it's not downplaying the pain that you're experiencing. If you're finding it hard to advocate for yourself, taking someone with you. For anyone who's joining here who's maybe got a daughter who's experiencing this, sometimes going with them to an appointment to help advocate. When you're younger, it can feel really hard to kind of push back against what you might see as the expert in terms of a GP, but actually you know your own body. And one of the big things we always say around treatment options and empowerment is we've got 4 questions we'd encourage you to ask if treatment options are being discussed. Why are you recommending this treatment? How will it help with my priorities? So your priorities might be bleeding, it might be pain, it might be fertility. What is that for you? What are the possible side effects? And what are the alternatives? So it allows you then to make that informed choice around what might feel right for you going forwards.
That's wonderful, Sally. And I can see people sharing what's working for them. If you look in chat right now, somebody's saying ibuprofen mini TENS machine called a Myuvi. Am I pronouncing that correctly? Which can be worn on the body and is very discreet. It really helped. So Mirena coil has helped, which helped periods initially, that then after a few years, my uterus became very weak. You're right with those questions because we've had some people, and it's sort of, you feel it that, being offered a hysterectomy when you're still hoping to start a family is not a good solution. So that is certainly a very important thing to discuss with your GP around your priorities.
Yeah, absolutely, absolutely. And I can see some of the questions here. Someone's asked if they've been recently diagnosed with it, but menopausal, does that happen? Absolutely. Some people will have adenomyosis with no symptoms at all, and because of other investigation, it may be noticed that they have adenomyosis. So, yeah, that later diagnosis is very common. Someone's asked around adenomyosis and infertility. It can have an impact on fertility. It doesn't always. So again, it's about understanding your own where you are in your own life, what your life choices are, to actually then explore the potential impact. So yes, it can have an impact, but it doesn't necessarily have to have an impact.
Wonderful, Sally. So I'm going to leave with this question now because what can people do now? Now, it does say in chat, is there a recording of this? Yes, absolutely. On the Henpicked Hub, as always, you can look at any of our lunch and learns. So please do share this recording with anybody else that you think it's going to help. We can all get talking about this. It shouldn't be a taboo subject by any stretch. And anywhere else, any websites that are super duper in helping people, whether it's connecting with the community or whether it's actually finding out more information.
Yeah, thank you very much, everyone. I can see someone said, yeah, my daughter was told several times by an A&E doctor to have a baby and that will fix it. We hear very similar stories around endometriosis. And it's about, and this is where I say, what are the priorities? Where is somebody in their life? And advocating for what feels right for you at that time.
Thank you very much. Thank you, Sally. And thank you to everyone for the discussion in chat. But thank you, Sally, for raising the awareness of adenomyosis and helping us understand what it's like to live with it. And more importantly, or just as importantly, what you can do if you're experiencing it. So thank you very much, all, and we'll see you on our next Lunch and Learn.
Thank you.